introducing Walt, our speaker. So a little bit about Walt. He's here on the Lieberhume Fellowship, and he's in the Department of Political Science, focused on aging. And before that, he was Director of Research and Analytics of the Oregon Healthcare Association, part-time lecturer at Institute of Aging at Portland State. He's got a number of kind of interesting pieces of work that he's developed in conjunction with this U.S. Special Senate on Aging, Health and Aging Program of Atlantic Philanthropies, where he was a visiting scholar in 2011. So his work focuses on public policy and aging, and that's why we co-sponsored this. And he's editor on the editorial board, and advisory board of the Journal of the American Society on Aging. His doctorate is in social policy from Oxford, and there he was focused on long-term services and policy reform in the U.S. And he holds a master's from the University of Oxford and London School of Economics. So today, Walt has a talk for us on policy change in aging societies. So welcome, I'm looking forward to hearing from you.
Thank you, Amanda. Thanks. Well, thank you, everybody. I'm very glad to be here today. As Amanda said, I'm Dr. Walt Dawson, and I'm the Fulbright Visiting Research Chair in Governance and Public Policy here at McMaster University this term. Going to probably start off with a little bit about the topics that I plan to cover today, and I would say that just a couple things. Anybody has any questions as we go along, feel free to stop me, but certainly I'm happy to take questions at the end as well, too. I do want to say that I'm very honored to be here through the Fulbright, honored to represent the United States, to represent my home state of Oregon, and the Oregon Healthcare Association, where I work. So a little bit about, I guess, my background. Really do live and work in Oregon normally. In addition to working at the Oregon Healthcare Association, which, by the way, is the state's largest long-term care provider trade association. OHCA represents kind of the full continuum of services for long-term services and supports, which I'm going to talk about a little bit further what that actually means. But also, yes, do teach part-time in the School of Community Health's Institute on Aging at Portland State University. So I've kind of worked on or in aging and health issues for a very long time. And I think that's kind of important to just kind of start out to tell you about where I'm coming from in terms of my research and what I'm doing. I started out very much as a caregiver and advocate for individuals who have Alzheimer's and dementia. My father had Alzheimer's disease and was diagnosed when I was quite young. Went from being kind of a caregiver and advocate to actually working in policy, initially at the state level in Oregon, and then actually nationally at the federal level in Washington, D.C. as well. Decided to do graduate work and ultimately my doctoral research on long-term services and supports and aging. I was doing my work in the United Kingdom. Initially, I kind of hoped to do a US-UK comparative work on the healthcare more broadly, but that proved to be a little too much for the doctoral dissertation, kind of just focused in on the United States, and then more specifically on my actual initial kind of passion being aging and long-term services and supports. So today I'm going to talk a little bit about kind of an overview of long-term services and supports kind of system and policy in the United States. Given that I live and work in Oregon, I might talk a little bit about the Oregon experience as well. Also going to talk about the previous kind of research that I've done on kind of the politics of long-term care policy in the United States at the federal level, and then talk a little bit about my research that I'm currently working on here in Canada. So I might just move that forward. Yes, please, if you could do that. Okay. Wonderful, thank you. So just kind of start out with some definitions. So first of all, there's some kind of discussion, debate about whether or not the proper or most preferred term is long-term services and supports or long-term care. To some degree, I think long-term services and supports is kind of the more term is used more broadly and more widely today. But both, I think, are certainly acceptable and have their own kind of meanings. in terms of long-term care, it's certainly kind of something that bridges both healthcare, social services, and housing. So that, I'll let you guys read the actual definition in a second here, that's all right. But to support the needs of people who are living with kind of chronic health, multiple chronic health conditions, and need some sort of assistance with their activities of daily living. I think it's important to talk about why long-term care or long-term services and supports are actually kind of a policy issue to think about. The first is kind of this demographic change that most kind of advanced economies are experiencing right now. You have kind of an aging population in the United States, you certainly have an aging population here in Canada. You know, this is due to people essentially living longer, advances in medical care, and so forth. So you kind of have this wider demographic changes occurring. Secondly, long-term care has very much been, or let's say the care for aging parents has very much been something that's been the role of the family, and in particular women. And with kind of changing, let's say, gender roles and certainly women entering the workforce in the same levels of work, not higher than men, that kind of dynamic is certainly changed. Certainly related to that, kind of family structures and changes. You have most people having fewer children, and as a result, there's going to be probably a smaller pool of potential kind of natural caregivers. In addition to that, you have individuals who are, I mean, you may be living in the same town or same neighborhood as your parents, but often people live in towns, different communities. They may live on the other side of the country, or they may live in another country entirely. So that kind of changes that dynamic as well, and has. And then, I'd say also very important to this, and why it's a policy issue, the role that public funding of long-term care plays in kind of this discussion, and that certainly is something that has kind of developed over time. And in kind of a U.S. example, I would say that very much, even going back to the Social Security Act during the kind of Great Depression in 1935, kind of providing retirement income for individuals so that they might be able to provide care and housing for themselves, but also more formally with the creation of the Medicare and Medicaid programs in the United States in 1965. So it's a very important policy topic. I think it's a policy issue and topic that doesn't get as much attention as it should. And there's several reasons for that, but I certainly think it's an important issue, and I think it's something that we will be talking about more in the years ahead. So a little bit about population demographics and population aging. This is information from the US, just kind of to give you a little perspective of where we are today. Approximately 14% of the United States population is over the age of 65. It's about 40 million people. That's a lot of people, but over the next kind of 25 years, you're going to see a significant kind of growth in that population from 14% to 21% of the population. And that's going to be about 90 million people, which is a significant growth. That's important because with age, particularly advanced age, the risk of needing long-term services and supports increases. Next slide. But so particularly that kind of advanced age is really, I think, the most important piece here. And this is just kind of some numbers on projections of annual population growth, the actual rate of growth per year in the United States. And it's actually this red line, the 85 plus population, or the oldest old, which is at that highest risk. And you're certainly seeing some growth each year going forward, but it's actually not for several years where that population is really going to grow quite significantly. But I think that's always something to just kind of keep in mind too. People talk about kind of a demographic wave that's washing on countries, and particularly the United States and Canada, but it's just something to think about, that that's actually some of those changes are a little more nuanced and occurring maybe a little bit further out than we might think. Next slide. A little bit of overview of the U.S. long-term care system. There's approximately 12 million Americans who need long-term services and supports at the moment. The estimates of that vary a little bit. I think that's probably kind of an underestimate, but let's say about 12 million. As I mentioned, certainly with age, the risk for needing long-term care increases. But in the United States, only about 58% of individuals are actually over the age of 65. You have a significant number of people, over 40%, who are under 65. Now, probably a large group of those people are actually between the ages of 50 and 65, so kind of reaching 65, but certainly it's just really important to keep in mind that it's not just an issue of aging when talking about long-term care. The population that needs long-term care tends to have multiple chronic health conditions such as dementia, Alzheimer's, diabetes, may have stroke, those type of things. But I think the kind of key tying component is the fact that people really need some sort of assistance with their activities of daily living. Activities of daily living being bathing, dressing, eating, transporting, toileting, and so forth. Next slide. Just want to talk a little bit about the actual settings where individuals tend to receive care in the United States. So long-term care is very much a continuum of care and services that I mentioned. So kind of the top or pinnacle of that continuum, you have skilled nursing facilities, or what you might call nursing homes traditionally. These are probably the settings that individuals think about most when you kind of think about long-term care. It tends to be the kind of most institutional setting of all. Kind of below that, you have more, let's call it community-based settings. That might be assisted living. It's a setting that's more residential, but provides 24-hour care and services to individuals. Residential care facilities are similar. That's kind of the licensing distinction in most states in the United States between the two, but they're quite similar in a lot of ways. Adult foster homes, which are much more of kind of a single-family home in terms of what it looks like. You might have, well, certainly in Oregon, 5 individuals or less that live in that setting and receive care from someone who lives in that house. And then you have in-home care agencies or paid caregivers that work for an agency where someone, well, they will come into your own home and provide services. And that's kind of the spectrum of like formal services, but the vast majority of people who actually need long-term services and supports are actually not being served in those more formal settings, but actually by families, by their family and friends. That's probably 80% of all people that need long-term services and supports in the United States receive it that way, rather than more formally. Next slide, please. Thank you. So I'm sure that everybody's well aware of kind of the high costs of the U.S. healthcare system. Gets lots of attention. Certainly the United States spends more than other nations, particularly OECD nations, somewhere around $3 trillion. Just highlight this though, just to kind of show where the spending occurs. And in terms of long-term care, probably about 5% of that is nursing facilities and continuing care, retirement communities, and then also another 5% of that is in kind of residential and personal care. This kind of setting here is a bit squishy as to whether that probably includes other things that actually long-term services and supports, but it's kind of a lot of that. So just over about 10% probably of healthcare, formal healthcare spending can be attributed to long-term care. So the actual payer sources for long-term care are important and very important to certainly the research that I'm doing and thinking about some of the challenges that face the long-term care system. So I would say much like Canada, the United States financing system for long-term care is highly fragmented, but perhaps surprisingly, public funding plays kind of a very significant role within the long-term care system in Oregon, or in the United States, and it's actually the kind of largest payer source. And it's particularly 2 programs, the Medicaid program. Medicaid is historically been a program for low-income individuals, particularly this means-tested program, particularly families and children. But it has also, since its creation, covered long-term care services as well for older adults and people with disabilities. In addition to Medicaid, the Medicare program is also, I would argue, a significant payer within the long-term care system. Medicare is very much a payer for acute care, hospitals and physician services for adults over the age of 65, but there is additionally some funding that are dedicated for individuals who may need, let's say, post-acute rehabilitative care, which takes place in a nursing facility or actually could take place in someone's home as well. And that actually ends up being quite a significant chunk of that public financing as well. The rest is kind of spread out in smaller pieces, out-of-pocket spending about 22%. Private insurance, the U.S. has had private long-term care insurance for a good amount of time now, 25, 30 years, but not significant uptake in terms of individuals actually taking out a policy. So you don't see extensive coverage. Maybe 5 to 7% of the U.S. population has private long-term care insurance. And there's some other public funds, largely the Veterans Administration for individuals who are veterans of the U.S. military and so forth as well. Next slide. So I just want to talk a little bit about, this is a blank slide, but talk a little bit about my research that I've done in the United States. So for my doctoral dissertation, I had the opportunity to go work in Washington, D.C. I received a fellowship to work on Capitol Hill for the U.S. Senate Special Committee on Aging. And I went there in the summer of 2009 just as the Affordable Care Act, which you may have heard about, also known as Obamacare, kind of overall U.S. healthcare system, as it was kind of being debated and marked up in the U.S. Congress. And so I had the opportunity to kind of work there as a staffer at the same time as doing my research. And kind of want to look at why, given kind of the various challenges within the long-term care system within the United States, why the United States doesn't have a more comprehensive long-term care financing system. And so kind of looked at a couple different time periods. Next slide, please. I think that's next. Wow. Looked at a couple different time periods to kind of do that analysis and research. But kind of guiding that was like several kind of theoretical frameworks kind of that draw on more political science, I suppose. The first being kind of an ideological argument. You know, do policy outcomes result from ideology? So in the United States, is it this kind of idea of kind of anti-statism, sort of kind of an anti-government outlook, small government, kind of a strong faith that the private market will kind of sort out all problems that you might have. The next kind of framework, kind of looking at the role that institutions, political institutions actually play in policy development. I think that's particularly important in the United States. Kind of the dispersal of power between the different branches of the U.S. federal government, between the U.S. Congress, between the presidency, and so forth, but also federalism, the role of the relationship between state governments and the federal government. And that's particularly important to long-term care, given that states play such a huge role in the financing and delivery of care. And then thirdly, kind of looking at policy actors, or what I might say are policy entrepreneurs, to kind of see to what degree their kind of influence on the policy process was. Whether or not that policy was actually driven forward by individual, it might be, let's say, an individual champion of an issue, or a stakeholder group that represents a constituency that is advocating for a particular issue, and kind of how those stakeholders navigated the institutional structure of the country. So it's kind of the kind of framework that I was taking to this. And then, next slide, please. I was kind of looking at kind of several different time periods. Most importantly, the most recent being the kind of the Obama presidency from 2008 forward, 2009 forward, and the Affordable Care Act, and a piece of the Affordable Care Act that was actually focused on long-term service supports financing. That was called the CLASS Act, the Community Living Assistance Services and Supports Act. And this was a piece of legislation that actually been floating around in the United States for several years prior to this debate on healthcare reform more broadly, that kind of got attached to this wider debate on healthcare. But it would have established an entirely voluntary national long-term care financing system in the United States that individuals would kind of choose to enroll in and pay a monthly premium, and after a vesting period of, I think initially 5 years, would be eligible to receive a daily cash benefit for services if you needed them. The problem was that this legislation was structured quite strangely, and it was entirely voluntary, and it's very difficult to get people to enroll in a program that's entirely voluntary, particularly something such as long-term care. So after about a year and a half, I actually early 2013, it was actually fully repealed. But it kind of, I think, provided a very good case study for understanding how policy is actually made in the United States, and kind of compared that to what happened previously prior during the Bush years, and then during the years of the Clinton presidency when President Bill Clinton had attempted to overhaul the U.S. healthcare system in the early 1990s. Next slide, please. Thank you. So I talked a little bit already about this, what the Class Act actually was, but a very interesting case study as well. Next slide, please. Thank you. I would say that the key findings of the research that I did were these. First, that, and I don't think these are necessarily groundbreaking in any way, but new large-scale social policies are very difficult to enact in the United States. Secondly, some sort of more comprehensive reform of long-term care is unlikely to occur, at least in the short term. In the short term, much more likely to see kind of, let's say, kind of market-oriented approaches to trying to expand the financing system, or making, let's say, incremental changes to the existing Medicaid program in the United States. But something that was very interesting was, from talking to people, a real kind of belief that some sort of public-private partnership was likely to actually take place if reform was ever, like comprehensive reform was likely, that would be kind of the approach that would be taken. And I think that was kind of an interesting finding from that research. Next slide, please. So I think the question now is why Canada? Why compare the United States and Canada? I think there's a number of good reasons to do that. Certainly, the kind of demographic changes that both countries are experiencing kind of sets that stage. I think, while certainly there are lots of differences between our two countries, like the shared cultural and historical ties of both countries, it makes that for a good comparison. Thirdly, the federal political system that both countries have is also important. As I mentioned, the states in the U.S. have such a strong role in delivering and financing long-term care. That certainly seems to be the case here, that provinces have that kind of real responsibility as well. So that's a good reason to compare the two countries. And then finally, I think there's a significant amount of individuals who are probably dual citizens of both countries, and just thinking about the fact that, you know, where people end up in their lives and with their family ties and work ties, you know, I think that just kind of understanding the two systems is useful from that perspective as well. Thank you. So a little bit about the kind of research design and the methods that I'm going to be taking. This is very much a qualitative study. It's based largely on in-depth, kind of semi-structured interviews with policymakers, with, let's say, policy elites more broadly. That might be policymakers, it might be stakeholder groups within the kind of long-term care and health system. It might be consumer advocacy groups, care providers and their representatives, as well as kind of policy experts and academics that think about these issues as well. To kind of reach the individuals that are most appropriate to talk with, kind of using snowball sampling, you know, talking to individuals and then having them tell me about who are they believe to be the key individuals I need to talk to, and just kind of continuing on with that list with every time I talk to somebody. And yeah, as I said, this is very much based on kind of sitting down and having these in-depth interviews to kind of assess to what degree the different kind of the role that different policy actors have, the way that institutions work, and the way that theology comes into play. And to some degree, kind of policy documents and legislation as well, looking at its influence as well. Next slide. So I think the main question that I'm trying to ask while here is, what are the key drivers of Canadian social policy? Particularly, what are the key drivers of long-term service and supports financing? And that's how my research and the approach I'm taking is to kind of answer that question. Next slide. So just a little bit about the Canadian system. I think as I'm sure you're all very well aware, the Canada Health Act is kind of the most important document, underpinning document within the Canadian healthcare system. Acute care, hospital, physician services are all kind of included, and that's essentially free point of access to individuals. But long-term care, long-term service supports are entirely left out of that. And instead, it's very much, long-term care is very much a provincial responsibility, and most provinces have to some degree created some sort of financing system, but that varies significantly by province and region. But it's kind of so far where I am. Next slide. Just a couple of very initial observations. Like I said, I've only been here about 6-7 weeks, so I'm hesitant to really say much yet. But certainly, I think that the role that political institutions play, certainly that kind of the parliamentary system and kind of concentration of power changes things. It makes it very different dynamic than in the United States. Reticent to say anything about ideology and culture yet. That's a much more difficult and challenging issue to look at. But I would just note that in my previous research in the United States, I was kind of surprised, kind of expected ideology to have a much more kind of direct link with policy outcomes, that people kind of took whatever their kind of ideological viewpoint was and kind of moved forward on that to kind of see the policy outcome. What actually I found with regard to long-term care is that people spend a lot of time worrying about and thinking about whether or not their policy proposal or plan would be not necessarily acceptable to opposing ideological viewpoints, but at least something that would not be attacked. And that had kind of a big impact on what was actually possible in terms of policy outcomes. Because if you're kind of always kind of thinking about what is actually likely to pass, the type of policy that you're going to come up with is going to look very different, I think. And then thirdly, cost concerns. That is something that is featured very prominently in previous research. And what I always find interesting about concerns about costs is that sometimes it can be a proxy for ideology, in the sense that those who are most kind of concerned with cost control are being driven by a more ideological viewpoint. And trying to kind of understand that, I think, is going to be quite interesting as well. And then, don't have it up here, but certainly kind of the role that kind of policy entrepreneurs or policy actors have in the policy process as well. It's something that I'm really wanting to look at further and hope to engage with. I think that the research I'm doing suffers from a number of kind of potential challenges and limitations, I should say. First off, the fact that it's kind of a short period of time that I'm actually here. This is a big topic to address in 4 months or less. And that's just kind of an inherent limitation of this, unfortunately. But that being said, I still think it's a good amount of time to actually kind of find some interesting insight. Secondly, access issues. So sometimes, talking to policy elites and policymakers can be difficult, right? Like trying to actually get access to the right people, and then actually finding enough time to actually speak with you. That's something that I think is always is an inherent challenge of this type of research, but something that just kind of have to fight through and work with. And then thirdly, the reliability of the data that's actually gathered. I think this is a problem, a potential limitation of any type of qualitative research, right? What people tell you may be not entirely accurate. That being said, like they may be, play up their role for whatever reason, or just have an inaccurate view and so forth. And you have to kind of figure out other ways to kind of corroborate the story that they're actually telling you. But I think that that's something that can be overcome as well. But just kind of some challenges that I'm kind of working through and thinking about as I go forward in my research. Next slide. So what I would really kind of like to do now is like talk to you guys. If you have any questions, thoughts, comments, perhaps ways that I might be able to strengthen or improve the work that I'm doing. Any observations? Kind of a discussion. Yes.
Well, I have a question. So it just goes back to the research design and methods. You mentioned possibly doing interviews with like policy elites, stakeholder groups, consumer advocacy groups, care providers, and reps, and just different policy actors and academics.
Sure.
And I'm just curious as to if you had specific stakeholder groups in mind and why aging adults themselves are not mentioned. I understand your focus on institutions, but given in Canada there's a really big push for patient involvement in research, and also the fact that we know that elderly adults are vulnerable to not having their autonomy respected, and so where is that balance between what care providers might want from a long-term care system versus what an actual aging adult wants in a long-term care system?
Sure, absolutely, absolutely. So I mentioned consumer groups, right? That tends to be probably it tends to probably be the best kind of stakeholder grouping to kind of be able to get the opinion of adults, right? And so that's probably would be my answer to that. Like that's probably what I'm trying to do. There are a number of consumer groups certainly, and consumer groups broadly defined. There's different ones that kind of different focus, but that certainly is kind of where we try to get that opinion. I mean, it might be certainly interesting to kind of hear just the viewpoint of certain individuals too, but to kind of frame that into kind of more of an actual framework and trying to understand how, as a group, individuals actually have some influence on the political system. Certainly talking to consumer groups, I think is kind of the key way to do that. That makes sense. Yes, question.
Are you planning to speak to Régent Hébert, the former Minister of Health and Care?
I would love to.
You should. He's
Yes.
now at the University of Montreal, and he pushed, he was in power, he was the minister for about a year and a half, 2 years, I think. And one of his pet projects, or the project he cared the most about was about long-term care. He wanted to create a mandatory contribution to a fund to help pay for long-term care. It was on hundreds of government, he went to the election and lost, but he's now a prof in the Health Administration Department in Montreal, and I'm sure he would love to talk about it.
Absolutely, absolutely.
So second is François Bélan here is coming for a month. What? Next week?
Yeah, only Mondays.
François Bélan is a sociologist in the same department as, I don't know if you know about François?
I do, yes. We know.
Okay,
Yeah.
so he's here, and so he sits a couple of doors away from Yvette.
Okay, yeah.
So it might be a way to get to talk to
Okay.
him.
Absolutely, yeah, I think that's an excellent idea. Thank you. Yeah. Yes.
I know you presented kind of an overview in your summary in the U.S. I'm interested in kind of the U.S. experience.
Sure.
So you said that you can't see long-term care as being a possibility in terms of policy in the upcoming years, and I wondered if you maybe had if you could give us a sense of why and what you saw and some of the details of the research
Sure.
that led you to that belief or conclusion.
Sure. Yeah, I mean, it's kind of difficult to say, like, when, I do think that some sort of more, let's say, comprehensive reform is possible at some point. So it's kind of difficult to say when, but in the short term, there's kind of a number of challenges that exist. Certainly just in terms of kind of logistically, right? So the fact that you kind of, to really kind of move forward or bring about kind of comprehensive social programs or any kind of reform, you kind of have to have things kind of aligned perfectly, so to speak. I think, for example, in the past, there's been, let's take the Great Depression in the U.S. You had a crisis that was occurring, but you also had same party control of both houses of Congress and the president being all the same. Right now in the United States, that's just not the case. We have a Democratic president, we have a Republican Congress, and as just on a kind of logistical level, till that changes, you're probably not going to see any major changes. I think that in terms of when I did my actual research on this, I was looking. This was kind of very much right at the end of the recession, and that certainly probably influenced a lot of opinions on kind of costs and spending. That I think is still very much those concerns over the cost of public programs has not necessarily changed, but that's something that as we kind of move away from the recession may play somewhat less of as a dominant role in that conversation. That really kind of very much dominated much of the debate about the Affordable Care Act much more broadly, and in terms of what and long-term care. So I think that kind of fiscal environment and focus on that, and then kind of logistical, institutional dispersion of power between different political parties means that you're not going to see anything in the immediate. At least that's kind of my sense from what I found. Yes.
So you mentioned that you expected ideology to play a much more kind of front and center role, but lots of political analysis from the States is is the institution stupid or that type of thing. So do you feel as though ideology might be a more potent force for change when the alignment of institutions is such that there's not as much constraint to policy development? So if you have a majority, not majority, but if you have a Republican president and the House is controlled by Republicans as well, would their ideology be much more potent in that context compared to today's context where Obama can't seem to get anything through that has the Democratic ideology?
So that certainly was my thinking, right, when I was kind of doing that research. But what is surprising is that actually when this was taking place, the Affordable Care Act in 2009 and 10, you actually had that control of Congress by the Democrats in record numbers, same party as President Obama. You had the kind of necessary features of the institutions to allow that to occur, and it still didn't. And that was what was fascinating. You had basically a proposal that was the Class Act was certainly innovative and would have been a major kind of change to the system, but I wouldn't say it was. It certainly was not a comprehensive overhaul either. It was more like a new addition to the system, and it was very much focused on this kind of idea that it was voluntary and it was an individual kind of taking responsibility for their own care, basically by planning for it, right? And that's kind of a different kind of that's not something that was I expected to see given those kind of the institutional framework and dynamics that existed in 2010.
Would that be related to something like party discipline, for example, where in Canada that could be a completely different situation with majority liberal government? It's one person says one thing and the rest of the crowd follows behind because they have to. Whereas in the States, there's many more ways in for lobbying groups and whatnot. So I guess the question is that still an institutional constraint, or is that an ideological kind of watering down?
I mean, I almost think it's an institutional constraint because there's just so many different ways within the U.S. system that a piece of policy can be either changed or completely thwarted, right? And just that kind of overriding concern with that, just I think had quite an impact on what actually was the final product. So I don't know. I kind of lean towards the fact that it's probably an institution, but it's a good question. Yes.
From this side of the border, when we look at what has happened with Obamacare and how it's compared to slavery, for example, how it's still compared to slavery, and when it looks from here again, one of the two major parties have gone completely insane. Do you have the same feeling in the U.S. that things are different now? That Obamacare, for many of us, it's actually something that comes from the right. It was Romney. It's not something that would ever work. We would accept here because we would see that be too much on the right. When now in the U.S. it's being portrayed as something which is very, very close to Stalin. Is that just us then, or so who's wrong, us?
No, I think that's a good observation. Yeah, the Affordable Care Act certainly has been a major change, but it is an idea that the underpinning of that is very much did come from a different ideological perspective, and that is interesting that has become what is actually major change, and that to some degree I wonder if that ties back into what I've found with my research on long-term care, that it's about what is trying to craft proposals that are just possible, right? That maybe aren't going to be accepted by the opposing side, but at least not attacked. But in the case of the Affordable Care Act, it certainly has undergone significant attacks over the last 5 years. But yeah, I think that it's to some degree is a product of that kind of concern about how to actually get something enacted. Question? Yes.
I would like to go back to at one point you said that 42% of individuals needing help with activities of daily living are younger than 65, and I may be totally wrong, but I would think that in Canada that portion would be much lower, and or at least this is the general perception. So maybe that's another way to think of maybe another difference between the US and Canada. I think, I may be wrong, but I think in Ontario at least, long-term care is seen as an issue of the elderly.
Right, right.
And yes, people would say, oh yeah, there is a residual population younger than 65 in need of long-term care. But even the word, I think even the concept of long-term care, I think people would use a different word to describe the needs of people younger than 65. And so maybe that may be another big difference between the two countries, that maybe in the US, it is seen as, it's not only Medicare, for instance, as you mentioned, it's mostly Medicaid, so which means that it's not it's not the administration in charge of the 65 plus, whereas here, I would imagine that it's still framed as, well, if you're not 65, this is not really, you're not part of the discussion.
Right, right. You know, I think that certainly when people think about long-term care, you tend to think about it as being an issue of older adults. I think that's
in the US too.
Yeah, in the US. I do think so. I think so. Like, I mean, certainly much more in kind of like wider population and so forth, and probably even a lot of policymakers and people that kind of work in government policy probably think that. But you know, it's interesting. 42% seems a little high to me, to be honest. But you know, that's one estimate. It might be a little lower than that. But even so, I wonder if it's so that population that's 50 to 65. I wonder. I have no necessarily any hard evidence to support this, but perhaps, you know, I wonder if we're seeing a population that is perhaps not as healthy as previous generations and has more kind of potential care needs. I don't know.
Is it based on self-reports to a survey where people are asked about their ADL limitations?
Right. So
it would be easy to compare that to data here in Canada.
Absolutely, yeah. No, that's very interesting, and that also has probably a big impact on the way that policies are thought about and crafted. I would think, if you're thinking about you know, the way that particularly groups that advocate on behalf of older adults versus groups that might advocate for younger adults with disabilities. So that's going to be something that I am interested in kind of think about and look at more. Yes.
I just want to touch on this point of like defining long-term care and like how that's perceived. I wouldn't necessarily agree that in Canada or in Ontario, just use Ontario as an example, that long-term care is thought of as something for older adults. If you look at organizations like St. Joseph's Foundation does a lot of work, and they're long-term care hospitals and establishments that they set up, but that also includes programming for like teenagers and young adults with drug dependence, or who are in need of like opioid dependence therapy, or things like that that are like not acute appropriate, so they're not appropriate for hospital settings, but also long-term. So I don't necessarily think coming from like a hospital sector or like Ministry of Long-Term Care, Health and Long-Term Care perspective, that it's necessarily restricted to over 65. I think it's very context dependent.
No, absolutely, absolutely. That makes sense, but that's interesting. You're saying that particularly about kind of Ontario and Canada specifically. That makes sense. Sorry. Yeah.
Are you still kind of comparing the UK? Are you still interested in that?
Yeah, I am actually. Why do you ask?
Well, I'm just curious to see whether there's actually a big difference there.
Yeah, no, I mean, certainly the UK would be interesting. You know, I don't know if I'm going to have the time to actually make that comparison, you know, and it would be a great thing to do. The UK recently kind of changed up some of their financing with, there was the Dillon Commission a few years ago that kind of looked at these issues, and that's kind of a significant change, and that's something that is worth kind of thinking about and exploring further. But you know, it's always a matter of time and resources, of course, for sure. But I would be happy to do that and go back to the UK and do a little bit more research on that. Yes, question.
From your research in US, you use Timeframe, so pre-Obama and Clinton era.
Yeah.
Are you going to use the similar kind of time frame in Canada? My first question. The second question is, there are differences between provinces in Canada,
Right.
and how this is going to affect actually your analysis,
Sure.
whether we are going to highlight any of these. The third question I have, before you would plan this research, there was Harper government, and you
Right.
had some hypothesis in your mind.
Right.
Now, as the government changed and quite unexpectedly, this is majority government.
Right.
How this is going to change your actually, hypothesis you think, just in your mind, that is going to influence your result?
Well, all right. So first, I'll probably answer the last question about the change in government. I had actually talked to several people before the election actually took place, and that was certainly was not the expected outcome of anybody I talked to. And so I may need to kind of revisit this now with this significant change in terms of having a majority government. But I don't know. I mean, the answer to that is I just probably am not in a place where I'm able to really know like what impact that's actually going to have, certainly in the short term. But it's certainly an unexpected change that's taking place in the midst of all this, and that's always kind of the challenge, and also interesting part of doing research is that sometimes unexpected events take place that might kind of change what you're actually looking at, or how you actually frame the issue that you're looking at. Your first question about the time frame issue, I think looking at the time frame piece was very important and helpful for kind of making that comparison in the U.S. That might be something that would be very helpful to do here too, just in the sense of kind of looking at what has happened at different times. But I haven't kind of narrowed in on any specific changes yet. Your middle question, I forgot, was what?
Is the provincial differences?
Provincial differences, yeah. So that's another challenge, and to some degree that's a challenge with any research in the U.S. too, that all states do things differently. I think that given the fact that located here in Ontario, that looking at the Ontario kind of system and its development and recent policy change would be kind of most useful. So I'm probably going I am focusing largely on that. And given the kind of short time period that I have, that's probably going to be the main focus of my work here, rather than looking at several other provinces as well. But I would certainly, I think it would be useful to kind of at least look at another province or two to kind of have that understanding of how things have developed differently. But it's again kind of it goes back to the challenges that just kind of are inherent to the structure of the timing that I face with this. Question?
Yeah, thank you very much. I'm really interested in the ideological and cultural differences and the way in which that is going to play into the analysis, and I'm looking forward to the results, given that there is this very different point of departure where universal health care is touted and often explained by Canadians as important to their national identity, and there's that history to that. So it is really interesting to me, and I'm an anthropologist, a cultural anthropologist, to think of how policymakers' discussions about long-term care will fit or be in tension with some of those values that we consider core to the broader universal healthcare system. So I hope that there's some room to explore that a little bit.
Absolutely. No, I look forward to kind of thinking about that more. I would just say very briefly in the conversations that I've had, there seems to be quite a bit of pride in the Canadian system that exists, and that is probably a very important component of policy, right? I think the outlook is different in the U.S., definitely, in terms of health and the system, and in terms of what people think, and there's quite a divide probably, and different viewpoints as to what is kind of supported by different parts of the population and by policymakers. I'm very interested to kind of look at how that actually translates though into like actual policy decisions too, as I mentioned, and whether or not it's much more kind of a direct relationship. And so It'll be interesting, it will. Other questions?
I just in mapping, in trying to map some of this out, I mean, you're coming at this at a time where there are also historical changes where dependency that was older people and people with disabilities is now kind of being connected in some ways too, so I think that's complicated, but in mapping it out, not to forget the roles that various kind of labor organizations and groups that are focused on work and work conditions play in Canada in the debates around long-term care. So the Canadian Nurses Association is a good example.
Absolutely, absolutely. I mean, that's almost a whole nother topic, right? Workforce-related issues related to long-term care, but that has a big, I would think, would have a huge impact though too on the system and policy outcomes and what. That's certainly a stakeholder group.
I think they're probably some of your strongest advocates, right? You're looking at the kind of pro-long-term care policy that I would say is coming from, or at least it's a key.
Yeah, that makes sense.
Any other questions? So please join me in thanking